So, you know, I know we're still waiting for people to join us, but for people out there in Facebook land, greetings and welcome to our 12th CalCare office hours sponsored by our lovely PNHP. These are the doctors who are fantastic, and then Healthcare for All Los Angeles. And you know what we do? Well, we are here to discuss a single payer healthcare bill that is in the legislative process here in California called AB 1400 or AKA CalCare. And we wanted to create a space where you could come and ask questions and talk about this bill, and we can get into the nitty gritty. As far as I know, we are the only organizations putting this on religiously every Sunday and talking about it for 2 hours. Why? Because we are solely focused on making sure that you, the public, even elected officials who may be watching us secretly, you know, anything, you know, hear from us. And we have made our primary focus to read this bill, to understand this bill, to reach out to resources that are, you know, the authors, everything is about this bill, okay? And so with that being said, I'm going to throw it over to Dr. Ron Birbaum, who is my esteemed co-host. And I didn't even introduce myself. I'm Jeanna Harris. I'm a nurse. Healthcare for All Los Angeles. I'm pretty sure you guys have seen my face plenty of times if you've logged into this before. And so, you know, I'm going to throw it over to Dr. Ron Birbaum, who's going to go over our basic principles of CalCare.
Welcome everybody, including Paul Newman with outstanding horizontal neckwear. Fantastic. Somebody's got to wear a bit of tie, if I'm not. Thank you, Jeanna. And yeah, this is number 12 that we've done. It's been great, and we're going to keep doing it. And we always start with just talking about the bill and its most basic elements. So, like, what is it trying to do? And so let me do a share screen thing. How's that right there? Yeah. I can even do better if I do that, so you don't have to see all the other stuff. Okay, so what is AB 1400 and what is CalCare, the program that AB 1400 would create? Well, AB 1400 was a bill introduced into the California legislature on the assembly side in February. It is a bill to do single payer universal guaranteed for all healthcare program in California. What does that mean? What would it mean for California to do guaranteed healthcare for all? And how would that differ from our current system, in which I think you would describe it as some healthcare for sometimes, maybe on a good day, and sometimes worse than that. And so what if things were different? What if they were otherwise? And it's important to have that vision. Like, you know, the bill is I have it here on my desk. It's like, 65 pages of, text, but it has a vision to do some really important things. And so that's what I want to run through right here. So the first sort of the cornerstone, I would say, is universal coverage. Or everybody in and nobody out. And that really means everybody. And that's like regardless of race or sex or gender or country of origin or your paperwork or immigration status or disability status or marital status, age, income, and anything related to ability to pay, because at the point of care, it's all free. And it's super important to do that. And it's actually also incredibly simplifying to do that. Like, one of the things that we spend a bunch of money on is never-ending determinations of eligibility and who's eligible for this and what formulary and what this and what that and who's allowed and who's in and who's out, and oh, you turned this age and now you don't have that anymore, or you made a little too much money this year, so now you don't have that. And so that would just end that. And just say, oh, you're a human being, you're in. So that's number one, universal coverage. And then the financing of things, of the paying, is a single public program. or what is called a single payer. And it's publicly funded through progressive taxes and would cover all necessary care in California. And that in and of is also incredibly simplifying because there's now like not a million different organizations that a doctor or a hospital or somebody might send a bill to. There's just one place paying for healthcare. And the benefits that are listed in the bill and that actually represent the minimum are more as comprehensive as anything that is out there now. And I mean anything. And it includes sort of all medical care, dental care, hearing, vision, mental health, prescription drugs, long-term care. We're going to hear a little bit more about that in some detail from Jeanna in comparison to what we have in place, which is abysmal. And the decisions, and this is important, the decisions about what care you need is between your doctor and your nurse and you, and not some insurance companies who are more motivated by other things like, are they making enough money, or does that cost too much and hurt their bottom line? It puts the value of health as the thing that we value, not the dollars. There's a freedom to choose your care provider. So under CalCare, there'd be essentially a universal network, right? Like there's almost nobody, I think, who would be outside of it, of major healthcare institutions and people who provide healthcare. And you would have, therefore, the freedom to choose your doctor or the hospital you like, as opposed to the current situation where you don't at all. And you can also have situations where you have some doctor you really like, and then tomorrow the plan changes and you can't go to that doctor anymore. That happens all the time. So another really important feature, this is all, and this is all words in the bill, is that it's free at the point of service. So it eliminates all of what we call cost sharing. So no more co-pays or co-payments. Premiums are eliminated, or deductibles. You just go to where you'd get the care, you give them a card that everybody will get, and you get the care. And that's simple. That's the idea. And this is a bill that describes the policy needed to do the things I'm going through here. And it's a big change. I think it's right to say that it's a big change. And one of the ways that it's a big change is that right now we have a bunch of people employed in things like an incredibly complicated billing, industrial complex, and other parts of our system where their jobs make sense in our current bad system, but there's other stuff that they could do, like provide healthcare or a whole bunch of other things. So we do know that because it'll change healthcare, it'll change healthcare jobs in certain ways. And so the program is very alert to that possibility and specifically describes what's called a just transition. So funding and programs to protect and support workers displaced primarily in the insurance industry. And then above all, not above all, but with everything else, is a really basic idea, which is that patient care is based on patient need. So that the money flows don't have anything to do with sort of financial incentives to avoid providing necessary care, or kind of elaborate schemes disguised as some idea of paying for value that are often just sort of risk shifting shenanigans, but is just payment for healthcare. And that's another big simplifying factor. So that is what CalCare would do. There's more details, of course. It's a 60-ish page bill. It can't possibly, I think Jeanna will tell us more about this. It can't possibly describe every decision in a new healthcare system. It describes in part how new decisions would be made. And so let me leave that there for our general introduction. Welcome people who've joined while we were getting going with our intro. And now turn it over to Jeanna, and I'm going to take down my screen sharing because Jeanna wanted to present some interesting stuff about what is the deal with, I didn't want to do that. What she'll tell you about, what she wants to tell you about.
Thanks, Ron. Last week we had a discussion, and part of it was touching on kind of like Medi-Cal, Medicaid eligibility, all these different guidelines. And so I remember there's a document that I have that I use for work in my space where we constantly are trying to get more patients benefits to cover their needs. Like, let's say the biggest thing, long-term care. Medicare is, it covers skilled nursing care. It does not cover long-term. And there's a difference there. So skilled nursing care would be mom had a knee replacement and needs some therapy, and she goes to a nursing facility for a week or two for that therapy, and then she goes home. That's skilled nursing care. Wound care, one thing would be feeding tubes, anything that requires, skilled nursing care under physician supervision is considered, skilled nursing, and Medicare will cover up to 100 days of that during one benefit period. And that's, so 100 days is considered a benefit period. After that 100 days, well, what do you do? And that's what I face each and every day. So after that 100 days is up, Medicare, you will exhaust your benefit, right? So let's say, unfortunately, terrible stroke or something like that, and you just can't go back home. You can't take care of yourself back home. You don't have the support. Well, and you need long-term care now. Unfortunately, this happens every day to people, common people who don't have resources, who had no idea how the system works. It's happening every single day. I can guarantee you it's happening right now to somebody, where they are facing this instance where I've exhausted my Medicare benefit for skilled nursing care, or I'm getting ready to, because we do let you know at about 70 days that this exhaustion is going to come up on you, and you have to have a plan on what you want to do, because at 100 days, I close the authorization, Medicare stops paying that nursing facility. It just does. And so that's where Medi-Cal or Medicaid in other states comes in. And that's where they pick up the long-term part, where, okay, you've gone over 100 days, you need nursing care 24/7, nursing support. And so you need to be long-term in a nursing facility. Basically, that's going to become your home now. And as sad as that is, it happens all the time, and we know it does. And so now Medi-Cal is paying that at a much lesser rate, by the way, than Medicare. And that is why nursing facilities are not thrilled to take these patients out the gate. I know that there are people who are trying to find nursing homes for their parents right now, and I apologize because I know that process is hard and stressful. But they do not want to take your mom or dad right out the gate, because why? Medi-Cal pays lesser rates than Medicare, and they do not want to take that right out the gate. Now, they will take it. Sometimes I have to tease it. And so I will say, okay, I'm going to give you 2 weeks skilled. So you'll get 2 weeks to do skilled therapy for this patient. And then they'll stay long-term and cross over to Medi-Cal, so that they get a little bit of, it's kind of putting some meat on the bone for them, because Medi-Cal payments barely cover expenses. I mean, I think a Medi-Cal daily rate would barely cover a nurse, for that day, and not including food and everything else that goes into taking care of that patient. So, that is something that will be it's very frustrating. It's a very difficult system. So anyway, I'm sorry, I'm going down a rabbit hole here, but I wanted to just talk about Medi-Cal. And the thing is that people were like, well, I can't go on Medi-Cal. Erica, I know you're on. I think this was your question about Medi-Cal, because they put liens on your home. And there is caveats that it's not directly, yes, a lien like just for applying, but there are property guidelines. And so I want to go into that, but I know that there's some questions popping up too. So I don't want to kind of pause, because this is about questions. It's not truly a presentation. So is there a question already, Ron, that had popped up that we want to discuss? Sorry, I'm opening chat.
There's a really good question that Paul Newman put in, but let me suggest that you do say that thing you wanted to talk, because it's so related to what you've been talking about. Mm-hmm. But then we'll get to Paul's question for sure.
Okay, awesome. So yeah, I'll go into that about property limits. So now, you're trying to apply for Medi-Cal, which we try to do if we know that this patient has a high risk of being long-term and they don't have Medi-Cal. we try to start this application process kind of right away because it is not fast. It does not take, it does not happen in a very quick way. And so it takes weeks to get done and through. So we try to apply for Medi-Cal, but what if the patient makes too much money? What if they just had just enough pension to where they won't qualify? And that's where I want to go over these property limits that, and I'm going to share my screen here. And granted, I am by far not the expert on this. It confuses me. I just want to show you so that you guys can see. I'm just showing you the information more than saying that I'm the expert on this. So I definitely want to give that caveat right there, because sometimes I read this and I still scratch my head, or my team comes to me with questions and I definitely scratch my head. So this is actually from Health and Human Services. This is the Medi-Cal General Property Guidelines. You guys see the screen okay? Okay, so then you see where it says individuals who are not eligible using their modified adjusted gross income. Here are your property limits. One person, 2,000 property limit. Now, property is not just meaning a house, okay? That means property like your life insurance, like all that is considered property. And it does define that here. Yes, property is defined as real property and personal property. Real property is land, buildings, mobile home, which are taxed as real property, life estates and real property, mortgages, promissory notes, and deeds and trusts. Personal property is any kind of liquid or non-liquid asset like cars, jewelry, stocks, bonds, financial institution accounts, boats, trailers, etc. Property that is not counted in determining your eligibility is called exempt or unavailable property. Countable property is included in the property reserve. And so, like I said, these just give you the breakdown, and I will drop this link in our chat. And Paul, because I know we pick on you for Facebook, if you could copy and paste it if you're on to the chat and Facebook, I appreciate it. This is public. You can just Google Medi-Cal General Property Limitations and you will find this document. So I'm not giving you anything exclusive, I'm sorry, but you know, it's just that this is there. And I think if you are going through this right now, or if you want more just to understand what's out there, then it kind of does make sense that you kind of learn. And like I said, not the expert here, I'm just showing you what this is. So, you know, here's some property exemptions. So principal residence, and I know that this is where I get confused, honestly, because I do know this is the fear most people have, is that there's going to be a lien put on their house for getting Medi-Cal, but then it says this is a property exemption. So I'm like, you know, it's hard for me to differentiate. I don't know anyone who works directly for a DHCS that can clarify this for me. Even my social workers I've asked still get a little confused. So if there's anyone out there that can clarify this, please feel free to chime in. And, you know, or, you know, send a resource. It's much appreciated, because like I said, right now, I'm just showing you this, the property exemptions, and then what is considered personal property exemption. So there's a long list here, but still the point I want to make, this is my biggest point. Why the hell am I going through this for healthcare, for long-term care, for anything with care in it? If it's not a Brazilian butt lift, why am I going through this to qualify for it? That, I guess, is my biggest question. Why do I have 4 pages of document sitting here justifying why my income can only be a certain limit to qualify for something, and why I have to break down, why do I even have to show you my property? Now, granted, I don't think Jeff Bezos is going to be the one applying for Medi-Cal, okay? And this is what I really want to drive home on this. This is a 4-page document of property limitations here, and it is literally to qualify you for Medi-Cal. If you cannot meet these guidelines, or, you know, or fall into the share of cost, which is basically if you are just above the Medi-Cal qualification, you may qualify for what share of cost is, which means you must basically spend down your excess income to qualify. So that means if I have just barely a little bit extra pension that I worked my whole life for, now I need long-term care. Now I've got to pay that down. I've got to pay that, get rid of that money to be able to qualify for Medi-Cal so I can get nursing care, so I can stay in a nursing home where I'm safe and cared for. That is complete BS. And it is a shame, and it is an embarrassment to us that we have to do this to our elderly people. So that's why CalCare is so important, because CalCare, AB1400, is taking Medicare waivers and Medi-Cal and combining them into somewhat of a Medi-Medi system, where this should go away. The reason why I say should is because there's still a lot of board to determine, but this should not have to exist because there should be no reason for it to. So like I said, I'm going to drop this in the chat. This time is for you to ask questions about the bill. I just wanted to give a little show of this. Like I said, it is something that even I still reference this document a lot when I'm dealing with patients and dealing with difficult discharge planning. When I have to come up and rub up against this, I kind of still refer back to this document because I get confused a lot because that's how this big bowl of spaghetti is. But I will drop it in the chat if you want to review it and look at it. But I just wanted to show that this document does exist and that when we were talking about it yesterday, which feels like yesterday, last week, it is actually a real thing. It wasn't just rumor or speculation. So I will drop this in the chat for you guys to look at, and I'm going to stop sharing, like I said, to make sure that you guys have time to ask questions. But I am putting the caveat out there again. This is by far not my strongest knowledge base because the way things are read and it reads, it's just confusing to me as well, which if it's confusing to me, then imagine how confusing it is to someone who just is trying to get their mom or their dad or family member the care that they need.
Super. I have a question about that, which is, and I would love it if you would share the link to that document, but that's one of them. But we're going to be getting to some questions that have been put through the chat in a second, but just in response to what you just said, is it your understanding, Jeanna, that the eligibility rules for Medi-Cal, and again, Medi-Cal is the program that pays for healthcare for primarily the poor in California, which is about a third of California because there's a lot. But the eligibility rules for Medi-Cal in general, and that you were kind of putting up there, are they the same or different for when the question is your eligibility for the Medi-Cal benefit for long-term care? Like, is it
there is a difference. There is a difference, but that income limit is still there. So unless you get emergency Medi-Cal, like you came in like a trauma and all that stuff, you came in the hospital, which hospital has a whole nother, they follow another process. But for the most part, there is a different application process for nursing home, but it's still not income limit. I'm sorry. This is where, like I said, going back to the bowl of spaghetti, look how I'm getting tongue twisted and tied up, right? Income limit and property limit are two different things. Now, you would think my money, my property, it's in my account, my property, but it's not. So the property limit does not go away. But from what I read, and I'll drop another link here from the, I think it was from the, oh goodness, brain fart, something about aging. Oh, American Council on Aging, I'm sorry. I was like, but it does define the income versus asset pretty well. So I'm gonna drop that link there too, for eligibility for institutional like nursing home, which means like, anyone who's eligible will receive assistance. And that, includes like nursing home care, but there's other waivers. You can get waivers too, but like one of the waivers is like basically the spend down, which means it's like, okay, we'll give you Medi-Cal, but you still have to spend down like $800 a month to do that. And,
So, and CalCare would make all this go away, right?
I like I said, I would say I'm 95% confident that it would. The only reason why I'm not 100% confident is because it does depend on how the board builds this out. This is why passing AB 1400 is imperative to impact doing any type of single payer across the country, because you can't just say Medicare for all. I'm not crapping on Medicare for all, but if I put every single American under Medicare right now, we're all going to hit the same roadblocks. We're going to fall in the same donut hole, and we're all going to be screwed. And we'll have access to care, which is great, but I don't want us to stumble and fall into the same holes that the elderly are falling into right now. So without filling in those holes. So yes, CalCare will be that fill, it will give us Medicare for all, plus fill the holes and cover us all, and probably save us a little money.
Yeah, the research says that programs like this save money net for the whole economy. Thank you. No, thank you for that. and we'll always be returning to the question of long-term care because it's such a big one and so poorly dealt with in our current system. And yeah, go ahead.
No, I just wanted to add. So what I was talking about when I first started this about the rates, okay? This goes into the medical apartheid Dr. Paul Song talks about, where it comes to like how we are discriminating, how as healthcare providers, not nursing and doctors, but like institutional providers are having to discriminate based on those rates. And I want to say having, I don't think it's all the time malicious. I'm saying all the time because yeah, there is a little maliciousness there, but all the time it's not malicious. You just have to pay your staff. You have to get supplies. You have to run, your facility. So with that costs money. If you take a bunch of Medi-Cal patients, I guarantee you will not be able to function because Medi-Cal rates are so much lower. And I know Ron, but how much difference the Medi-Cal rate is between PPO and Medicare. And so with that, it's a disservice to our elderly, honestly, because they're stuck in this Medi-Cal world when it comes to long-term care, being basically kind of considered second class and second priority to the Medicare patients. Even in the nursing homes where I've worked, they put the long-terms on another hall. Once they cross over, you don't stay in your same room. You get put onto the long-term wing, and the staffing ratios are higher, everything, because you're supposed to be lower acuity, but still, actually they're not lower acuity. A lot of these patients have dementia, need a lot of one-on-one focus and just watching to prevent that they don't fall. So, but because of that, it's the rates that are really causing this going on there. So I just want to drive that home too. That the rate difference is such a disparity between Medicare and Medi-Cal that it really does cause a change and difference in care. And I know that there's a bill right now that's expanding Medi-Cal, which I'm not going to say it's bad because, people need care at the end of the day. But if that's the only thing that they're trying to bring to the table and say, look what we did, yay, that's not good enough.
So, let's go to some of the questions that have been posed in the chat because there's already a couple, and encourage really office hours is about questions about this bill and answering them. And so let's start with one from Paul Newman, which well, Paul, do you want to you wrote it out. You want me to read it? You want to read your own question? What do you want to do? Want me to read it? How about I'll read it? So this is what Paul said, but interrupt me if you want to read it. Okay. Under the category of waste and fraud, according to the NIH, there are healthcare providers, hospitals, and physicians who provide unnecessary procedures, tests, and use of facilities for profit. How will this bill address this important problem? So it's a good question. So I think the first part, let me undertake a little bit of answering of it, but welcome all with knowledge. So first thing is, well, how will the CalCare, how will it pay for any care whatsoever? And then you can say, well, then how might fraud happen and what would be the anti-fraud elements of the bill? So CalCare defines two kinds of providers of healthcare. So the first are institutional providers. And an institutional provider is sort of like a hospital, although some other organizations could qualify. Actually, a long-term care facility could be one, and there would be others, but they're more like places with multiple people working for them that provide healthcare, and they're going to be paid by what are called global budgets. And global budgets are a big feature of like contemporary single payer policy and are used in Canada, for example, for funding hospitals and that kind of thing. And so the basic idea is that there is a sort of a negotiated lump sum that an institution gets to provide care. And there isn't profit budgeted into that budget, and it's a negotiation between the institution, which is contracted with the CalCare board, And so that has one set of a couple anti-profiteering elements in it. One of which is that there isn't just providing extra care that isn't necessary. There's really like no incentive to do that because there's not extra money coming for that care for that institution. But we do have an overall sense of how, much places like hospitals spend. And it changes over time based on things like technology and that kind of thing. And so there's a periodicity of renegotiating those global budgets. So then the other way that people are paid is if they're individual providers contracted, they're paid on a fee-for-service basis. So they're actually paid for every thing they do, which is either evaluating and treating a patient or performing a certain procedure. And so people sometimes worry more about fraud in those settings because you can what prevents you from just reporting a whole bunch of things that say never happened and that kind of thing. So one of the things is that I think it's right to say that under our current system, there is also a lot of fraud and abuse, and both insurance companies are defrauded and the government is defrauded. But it's and one of the things that facilitates some of the current problems with that is the complexity of our healthcare system. In other words, like when things are very complex, it's easier to kind of like hide behind that complexity. So when you have a single payer who is paying individual providers, and then you have this one billing system that is looking at all the numbers, you can do one thing right away, which is you can start to see outlier behavior, things where some particular person is reporting way too much of something or other. And then that can then prompt an investigation. Also, the bill has some other required reporting that will also help with identifying that. In other words, the participants are, which should be almost everybody, are required to report some about what they do, and all of that has a kind of anti-fraud built into it. One thing though is that there is a sort of incorrect belief among some that the biggest driver of healthcare costs is physician-induced demand for stuff that people don't need. There is some of that, but it's not the biggest driver of our healthcare costs. Biggest driver of our excessive healthcare costs are the individual high costs of providing care, which include a whole bunch of things like the highest pharmaceutical prices in the world, and also by far the highest administrative costs in the world, because we have an incredibly complicated health system. So I know that's as I sometimes want to give a long answer, but those are some of the things that are kind of like anti-fraud that are in the bill. But any other thoughts from anybody else who's here who've been recent bill readers? Yeah, Bill?
Dr. Bill.
Short answer is a board. We'll have a board that will review on the fee-for-service side for providers, and then the global budget side, as Ron mentioned in some detail. So that, doesn't exist. What exists now are negotiated terms between third parties. So those third parties are under no obligation whatsoever to contain costs, and so that's where these runaway expenses and even fraud takes place. It's all done behind closed doors. It's done in the morass of that spaghetti that Jeanna talks about all the time, that diagram that we've shown, the spaghetti thrown on the wall. And it's also done with malice, in my opinion, It's done under an abusive business practice model that is extortion, where they charge for those services based on what your life is worth to you, not what it actually costs them to provide those services. That's how the mafia works, right? Hey, that's a nice kid you got there. Be ashamed if something happened to him. And that's what they charge you for it, instead of it costs us X amount of dollars to perform these services. We're going to take a little bit above that. Now, I see, I think, was it Dr. Sarah who asked that good question? Dr. Sarah asked a good question about what's more ethical, the UK socialized, or say a system like single payer, or a system maybe that even partially commercial payment, like say in Switzerland, for example, where they've kept commercial insurance systems in place, but they've regulated down the prices. So, you know, like most of us here are familiar with the term, perhaps, or maybe you don't know, what they call a medical loss ratio, where the loss to an insurance company is what they have to pay out for your claims. That's a perverse notion. That's what they're in the business for. Why is it considered a loss? But anyhow, that's what they consider a loss, and they have to pay out. If you regulate that loss way, way down to the single digits, you know, like say that they can only make a profit of say 4% or so, that's what the situation is like in places like Switzerland. So they're not going to make a whole lot of obscene profits at 4%. So that approaches what you get with a single payer system, which is 0%, you know, or just administrative costs, like we know traditional Medicare operates at like 2% administrative cost. So it's 4% compared to 2%, you know, for Medicare. So basically, that right now, you know, private or commercial insurance is 20%. It's 10 times that profit margin, and has all that opportunity for fraud and abuse thrown in. So, you know, we will have under AB 1400 a board that reviews these payments that are made to providers, and also the negotiated global budgets that Ron talked about between hospitals and clinics.
So thank you. And maybe then a little related thing is, and Eli, we're going to get to your question, I promise you. What's one reason why we do 2 hours? So we're like, we got the time to really sink our teeth into some stuff. And you asked a really good question, but because it flows a little bit naturally from the last one too. And let me kind of also add a little bit to this question that Dr. Sarah Dean asked. So Sarah was earlier today, if I understand my facts correctly, was presenting about AB 1400 at the Progressive Democratic Club, which I think I also heard from her endorsed AB 1400, which is great. Thank you for making that presentation too. And she got a question there, which was, under which system do providers deliver more ethical, parentheses, less fraudulent care? UK socialized or single payer? And so underlying that question is sort of, what do we mean? What's different, or what's the same, or what is one a single? What's the difference? So the United Kingdom has kind of a complicated thing, but a simple thing. So they have one universal public health system that's called I'm blanking. It's come on, help me. It's the NHS.
National Health System.
National Health System. Thank you. NHS.
Sounds like it's something very simple.
No, it was like a simple, but you know how that is when you're and the NHS that's a truly socialized system in all senses, because it's paid. Everybody is covered by it. it's paid for by tax dollars, and then it owns buildings and it employs people and it pays them salaries. And that, but it's also not the only system in the United Kingdom. So they also have so that is a truly economic socialized system, but they also have a separate private system that one could buy insurance from or could get as an employment benefit. And included in that is that providers can work in both systems. And actually CalCare wouldn't do those things. So I'll explain that. So CalCare is, first of all, it is, I guess for lack of a better word, a socialized insurance system, so that there's one, like all of the insurance is done by one company, and that company is all of us. It's not a for-profit company, it's just us. I mean, the government of California representing all of us. And it then makes those two kinds of payments, but that doesn't mean then that I mentioned before, but that doesn't make all those folks or those institutions owned by California or employees of California or something like that. There's still a private sector, that there's limitations on the institutional side of the private sector of essentially eliminates their being able to be for profit. And so there's, in that sense, it adds a regulatory element to what the private sector does. So then having given that background, your question of like, well, where is there more fraud or less fraud? So, you know, there is, there's no system where, well, actually there's two parts to that question. One was, which place is more ethical, or what's more ethical? And the truth is that people who practice or who do healthcare have ethical challenges almost no matter what system you put in place. Let me give you some examples. So if you're being paid fee for service, you have an incentive at times to do more. For example, like I'm a dermatologist, and if I'm being paid by the piece, I maybe do more skin I mean, I try not to do this, but like the incentive would be do more skin biopsies for cancer, and I will make more money. And so when paid in that way, I have to sort of check whatever, you know, nefarious tendency I might have to do that. But say people are paid a salary, they actually have some other incentives. For example, they might have the incentive to not stay overtime, not spend more time at the office than they would otherwise need to. And maybe sometimes somebody needs you to. And, you know, so they just have to, and, you know, that's what we hope, like professionalism is the ability to apply ethical standards beyond merely what financial incentives are. So I would say both systems have some of those, potentially have problems like those built in. So I actually don't think it's a totally, one can give the simplest possible answer to that. But I will say that CalCare at least envisions a system where, for the most part, the interests and needs of patients are pretty well aligned with what healthcare providers want to do. And there's not a lot of barriers to healthcare providers also doing what they think should be done on patient behalf. That was another long answer. So let me go back to our questions, because Eli had a question which we did not want to forget. And Eli, welcome, by the way. And would you rather say your question, or do you want us to read it? You want to say it?
Sure. I was just wondering what would happen to people who are on Obamacare in California, or people who are on private insurance right now.
Jeanna, do you want to answer that?
Oh, sure. So Obamacare, what part of AB 1400 does is it has us go to the federal government, and say, hey, I want my money to go into another pot. And so we're going to take this money from Medicare, Medicaid, like all the federal money we're getting, we're going to put it in one pot, and we're basically going to create our own healthcare system. It has not been done in the United States yet. It was done in Saskatchewan, Canada, and that is what started the Canadian healthcare system that they have today. So our goal is right now with AB 1400 is to trying to become Saskatchewan. And if I'm butchering that name, I'm sorry, but I think that's right. Kind of. I mean, you know, I don't have a Canadian accent, but I'm good enough. And so that's what we're trying to do. So it necessarily, I don't want to say it just goes away, it improves. Okay, so you will get Obamacare plus some, and without having to pay that premium. And so, you know, I know people, this is a bigger question in the union world that we've been faced, which is what happens to my hard struggle fought for union benefits. But everyone asks a very similar question about what happens to my current stuff. What happens to my current stuff? And it gets better. You know, because right now you're paying, most people that have covered California Obamacare are mostly still working, just, you know, they just can't, you know, or they're self-employed or something like that. And so they still pay taxes to healthcare for Medicare, Medi-Cal, Social Security. And, you know, they're still paying taxes and still having to pay their whatever premiums they have to pay through Covered California, or AKA the Affordable Care Act, which some of those premiums, depending on your plan, and I'm just like Ron, I'm long-winded too, I'm sorry. But you know, but some of those plans, like if you have, like, I have employer-based insurance, right? But I was curious and I went to the Covered California marketplace to see what a single 33-year-old person, and I put in a salary of like 40K, because I put in a salary, whatever my salary would have been for $15 an hour. And while there are some insurances like, oh, your premium's only going to be $40 a month with Oscar, which is a plan here in California. Well, guess what? You have a $6,500 deductible. And then you have, you know, your co-pays. So it's like you actually are paying way more. You like, the lower the monthly rate is, the more you're going to get bit on the back end having to pay for the care. So you still have to pay for care, and you still have to pay your premiums, and you still have to pay Medicare and all that stuff, those taxes too. So you're paying a lot of money still. But when if we can get those federal waivers and basically put it all into one pot and create CalCare, then you won't have to be paying all of that extra stuff. I mean, we're being nickeled and dimed basically. And for what? For people like me to kind of deny your care. And so it's like, you know, you kind of, that's how it's, so, you know, kind of, I'm sorry, I'm just kind of like long-winded way. You will still get your insurance. You will likely still keep your doctor, unless you want to divorce your doctor, then divorce your doctor and go find a better one. And without having to pay deductibles, co-pays, and you will just go show your CalCare card and they're going to say, thank you, go have a seat.
And, but Eli, you know, I want to add a couple things onto that, although that are just some other ways of thinking about it too, which is that, so something that CalCare is not, is it's not a program that's like, okay, there's the people on Obamacare and they stay on Obamacare, and there's people getting employer health care and they would stay there. And then we'll just fill in the cracks and cover everybody else with this other program. It's a single payer program. And so what it does is it brings together all of those resources and puts them in one pot. And it would achieve that through applications for waivers of federal law that allow the state instead to be like the Obamacare money, instead of going to like individual Obamacare plans, to go into this pot. And then some taxes and Medicare money and all these different sources, and puts them in one place, and then sets one very high standard that is higher than all of the existing program standards for care. So exactly. I do want that, like, you to know that, because it's not, because it's important, because that's what it is. And so we want to get the facts straight, but also that why do that? And the answer is that the complexity of our current healthcare system is one of its big Achilles heels. It's one of the things that it's the biggest thing probably that drives its expenses. And when it's reducing that complexity is one of the biggest single source of deadweight savings that allows you to cover everybody. And the numbers on that are big and actually quite solid. They've been looked at again and again. So,
right.
So
I just want to I want to try a fun thing really quick that popped up in the chat to say the name of the Saskatchewan River. I'm going to try it. And okay, so it's, I'm going to say Kisaskatchewanissippi. That's how I'm pronouncing that. Kisaskatchewanissippi. I'm getting a thumbs up. Close enough, right? Okay,
I'm going to go with Jeanna on that one.
That was your 30-second or your 20-second commercial break. Now back to CalCare office hours. I'm sorry. I just saw that. I said I want to give this a try.
Just flexing. Gina's flexing.
Well, can I jump in?
Sure.
Again, thanks. So, so once again, I'm going to try and, you know, because my simple brain is looking for simple answers. I would say a simple answer to that terrific question of Eli's is that Obamacare was a way for some people to buy insurance. So it subsidized insurance for people. It made it more quote unquote affordable, right? Like the name, the Affordable Care Act. Unfortunately, in its attempt to make health insurance affordable, it offered crappy coverage, you know, like these bronze and silver plants and all that stuff. So, you know, my first expression would be nobody would have to buy any insurance anymore. So under AB 1400 California, under Medicare for all across the country, that's what we mean by that. You don't have to buy some crappy plan. And then Dr. Rich Wynn, he said it best, that it actually creates parity. So maybe, Rich, maybe you want to go ahead and like.
Sure, thank you, Dr. Bell.
That time. Yeah, thanks.
So I think the way that I see it is, you know, the current system right now is a tiered system, right? We have people who have these bronze plans, silver plans, gold plans, platinum plans, etc. And a lot of this has to do with, you know, their financial situation or etc., socioeconomic situations. And so we have a tiered system as it stands. And by no means is there any sort of equity in that, right? What AB 1400 does is it eliminates this tiered system. And it allows for there to be true healthcare equity, which is I think what everyone deserves. We deserve a high quality standard of care that everyone can get, irrespective of their socioeconomic status.
Absolutely. Doc, I see Dr. Saradine has her hand up too.
I think the other thing to remember is that Obamacare did not change the rules of the game at all. The rules of the game are still being determined and driven by the insurance companies, and they're highly toxic and corrosive. So under Obamacare, I don't know, Rich, I don't know if you had to do this at the hospital, but I remember when my husband started practicing hospitalist medicine at the local hospital, at the end of the year, they have that performance review. And I remember he showed it to me. It was his first year practicing and like my jaw dropped. So it's this grid that shows a number of patients he's admitted that year, how many days he's kept them in the hospital, and then he's punished for any excessive days. Like if he shows a high rate of taking care of patients, because the hospital gets paid more for readmission than for every day that a patient stays. So from the hospital's point of view, they want the doctor to kick the patient out. And if the patient's health deteriorates, they don't mind them getting readmitted because they're going to get paid more. So establishing Obamacare didn't change that, right? So the only way forward, we walk away from this absolute absurdity, repugnant, morally completely devoid system, is by abandoning the insurance companies. Sorry.
So can I add to that really quick? Because I just want to clarify something. That is one thing I'm not defending these people by far, but because I work with it, I have to. We actually fight the hospitals on that, because that is where, so when we get a patient that comes into that ER and we know they're a readmit, we're going to try to divert them. we're going to try to say, you know what, they didn't follow up with their doctor. We're going to create an urgent appointment, because readmissions actually look bad upon us. We actually report that crap. And the same thing, it's like on our end, I don't want to say our, but their end, they have to, our readmissions, like we have high readmissions, it looks bad. The same thing with hospitals too. Hospitals actually do care about the readmission rates, because it looks bad on their reimbursement rates when they go through reviews and stuff like that too. So it's a fine balance. Now, there are some hospitals who will fluff things. And if you come in with a chest pain that could be ruled out in the ER, they may say you need an observation, and you really kind of don't. But because it's chest pain and it's ambiguous, they can get away with it, and they'll admit you for chest pain. Under observation status, which if you have a PPO, observation status is very, very expensive to you. But you know, so like I said, we fight we fight them on that admission, because we don't want the readmission at all. The hospitals are now catching up to that too. They don't want the readmission either. So we are trying to get rid of that. Granted, it is still, like I said, problematic AF. And yes, our doctors are scolded for their readmissions if there's a particular doctor. And I don't know why it's the hospitalist that's getting scolded. It should be the PCP. Sorry to the PCPs, PNHP, don't beat me up. But honestly, the PCP's job is to maintain that patient outside of the acute setting. The acute setting is coming in, we stabilize you, and then you go get your outpatient care there. You follow up with your pulmonologist. You may follow up with Ron for your derm. You may do all these follow-ups, because we've taken care of your acute life-threatening illness in this acute setting. But unfortunately, the hospital system is being utilized in certain instances like that, and the doctors are being penalized. It's sometimes the wrong doctors, in my opinion, but it's just a really brutal ass system. Why? Profit. So going back, so sorry, you're exactly right. That was a long-winded way, but it goes back to profit. And then I see Dr. Bill and Rich, you have your hands up too. Oh, Rich, you have your hand up first.
Yes,
okay,
was pointing at me. Yeah, so I agree. I mean, the fact is, you know, right now it's a profit-driven system, and essentially the public option, Obamacare, ACA, whatever you want to call it, all it does is really perpetuate healthcare inequity and perpetuates this billion-dollar healthcare insurance enterprise that puts profit over patient care, over patient needs. And so with AB 1400, CalCare, et cetera, by removing that, you'll be able to put the patients over the profits first, which is what it should be.
And Dr. Bill next, but there's Eli, you have a follow-up question that we can address, and maybe we can even get a diagram that will help up. In fact, I might even ask if Dr. Sarah Dean would, if she's able to, because she has a pretty good diagram in a talk that she gives of the money flows. But did you?
Yeah, I can share it.
Would you? But while you're looking for it, Bill, did you have a?
Well, I was just gonna kind of add to what Jeanna was talking about, and you know what was first mentioned about, and Dr. Sarah was talking about performance reviews. I was on a what we called UR committee, utilization review committee, when I was working in the hospital and hospital setting. And as a representative from the emergency room, I was constantly fighting that, you know, for not releasing patients too early, because they would just bounce back to the ER, or at the very least that they were followed closely once they were released. And you know, I would see patient after patient after patient they were released for, you know, after being admitted for a complicated medical problem, and then given a 2 or 3 month follow-up appointment. 2 or 3 months they were supposed to be fine for 2 or 3 months before they were going to see a doctor. It was completely absurd. And, you know, so I thought, what the hell is motivating, you know, these doctors to decide that? I mean, are they just too busy in their clinics? Are they being directed by their department chiefs to do that? You know, who's saying that they can't see their patients any sooner than that? Who is saying that they have to kick them out of the hospital? And I got some good direction on that from PNHP. Actually, they published good data on length of stays in the hospital in the United States compared to other countries. And we have one of the lowest length of stays, especially for relatively routine things like for obstetrics. You know, we're all familiar with these kind of drive-by hospitalizations for delivering a baby, you know, where moms and babies get kicked out of the hospital so quickly. That doesn't happen in single-payer countries and universal healthcare countries around the world. They are not kicked out of the hospital like they are in this country. And so, you know, so there is so much evidence and so many good templates, models around the world for how they're doing this correctly. You know, I'm absolutely certain if we went to the Canadian model tomorrow, or UK, or even Switzerland tomorrow, we'd be doing a better job, you know, in this regard as well.
So let me, I'm putting up as a screen share, and then let me, in the interest of trying to get at Eli's question, a thing about money flows, and there's a couple of slides in Sarah's thing that maybe that I could share, or you could speak to them, but let me start with my version of the answer. But one of the good things is sometimes we can kind of provide more than one answer, because everybody has some like different angles. So to repeat your question, is really also really good one, really important one is, you said, do you think you guys could draw a flow diagram of where the money and care come from and go to under CalCare? I'm still confused on how you'll get rid of the, one second, the tiered system with my chat move. We'll get rid of the tiered system if private insurance companies are still in operation. So first, let me go to the end of what your comment was there. So one thing that's in the bill is that a private insurance company, it's not that they cease to exist, but they're not allowed to sell an insurance product in California that duplicates the services that CalCare does. So that means that, except for maybe a tiny sliver of like an add-on thing of if you got hospitalized and you wanted a single room or something that wasn't sort of built into the very comprehensive benefits in CalCare, they wouldn't be allowed to sell insurance in California that duplicates the program. That's a basic feature of most single payer plans, and it's a feature of CalCare. So then you say, so hearing that, where does the money come from? And then maybe, Sarah, I'll turn it over to you for a second to talk about how does it flow out, since you also have that slide for that, and I can put that up. So, but I put this slide up, which is to say, first of all, where is the money coming from right now in our healthcare system? And a pretty good study that was done a few years ago showed that already 71% of healthcare costs in California come from public sources. So that includes all the money that's paid in taxes to the state and to the federal government, and then comes back in the form of Medicare, Medi-Cal, the tax subsidies for employer-sponsored insurance, because did you know that? Like, by not taxing employer-sponsored healthcare, that's like a big tax break for businesses, because if it was income, that would all get taxed. So then the government spending on healthcare and some of the other things from the Affordable Care Act, that amounts to 71% of what's spent in California. So what's the other 29%? Well, that is money that businesses pay for insurance for their employees, and then premiums that people pay, and then all of the out-of-pocket expenses which provide barriers to care that people pay, and then the small number of people who just sort of purely buy insurance or pay for healthcare in other ways on their own. So the first idea of doing a bill in an individual state like California is that you want to gather all of the existing public expenditures. So you have to gather the money that the state is spending, and then gather through the federal waiver process the federal money that is coming into California. And then that gives you most of what you need. And then, but there's a little bit of difference between what that is and what you need to cover everybody. And that would put into place some new taxes. And so that still would remain to be seen exactly what those new taxes would be. But everybody who does the math on these things observes that those new taxes would be less on an individual basis and on a collective basis than what is currently being paid for privately by people to get healthcare. So that's the flow of money into the system under CalCare. Collecting existing sources plus some new taxes. But those new taxes are less money than people are currently paying out, and they would be progressive because we tax progressively in California. There's a set of different ideas of how that taxation would be done. But then let me put up the other slide. It was number 8. And do you want to, Sarah, do you want to speak to this slide? Because this is how the money would go out, would flow out.
Sure. So many thoughts are going through my mind as I'm listening. But yes, AB 1400 establishes the CalCare Trust Fund. And as Dr. Ron mentioned, CalCare Trust Fund would be the catch-all place for all of those funds, the federal funds that he mentioned, and any funds that would come from a state-based progressive tax plan that might be implemented to make up for that teal sector of that pie chart. So CalCare would then be either paying out a global budget to an institutional provider. An institutional provider is like a hospital, a nursing home, a healthcare facility. Those would receive an annual global budget. That's the purple arrows. And every year, the global budget could theoretically be renegotiated. Under the global budget, included in the global budget would be salaries for healthcare providers, such as physical therapists, nurses, doctors, and those would be salaried providers. A doctor, a provider could say, actually, I prefer to be fee for service. And those are the doctors that you see receiving the orangish yellow arrows. So they're being reimbursed directly from the CalCare Trust Fund as fee for service. As a patient in the pink side, you can go to absolutely any one of these providers. You could see a doctor that's salaried by the hospital, or you could see a doctor that's being paid fee for service at their private practice. It doesn't matter to you as a patient. You're going to pick whatever doctor you have a good connection with or you feel would be the best to take care of you. You are not making any payments at whether not as a copay, not as a deductible. And the other thing I think it's interesting is that suppose you haven't enrolled yet with CalCare. As someone who's worked with, like, my community is largely immigrant, so someone in my community could show up at the doctor's office and enroll right there on the spot, which I think is a really great feature that CalCare makes sure that it's mentioned in the bill. Is that, Ron, kind of what you were looking for?
I thought that was beautiful, but Eli, what do you think? Did that make sense? And do you have any follow-up question based on what we shared there?
That makes a lot more sense. Yeah, I think you covered everything. Thank you.
And thank you, Sarah, for the pictures. Everything is better with a picture.
Definitely.
Thanks, Gina.
And Nicole, I saw you had a question in the chat about, like, the legislative, where things are in the legislative process. Mm-hmm. And so the bill was introduced in the legislature, as you mentioned, in February.
Yeah.
And then in in April, there was a decision made primarily by the bill principal author, who's Assembly Member Kalra, to do what's called turning it into a 2-year bill. So the California legislative cycle, bills can be either like 1 year or 2 year. And so it will reappear in the Assembly Healthcare Committee in January of 2022. But that doesn't mean there's not important work to be done between. Yes.
And then I saw, Rich, you had your hand up, or did you take it down?
I did. It was just, when I was looking at Dr. Dean's slide there, it reminded me that there another key difference between, the system we have now, or whatever we want to call it, broken system that we have now versus what CalCare would give us, is that, you would have the availability of any doctor, right? It's not, there's no more, you have to choose within your network, or you have to choose, only specific doctors. You'd have the ability to, do your research and find out which doctor is the best one for me and my condition. And just a quick aside, I recently encountered this where I had a patient who had a very specific disease. And so I wanted that patient to see a very specific doctor who is world-renowned for this disease. And unfortunately, that doctor is not in network. And unfortunately, they weren't able to see that particular doctor for their disease. And it's sad because that doctor literally lives half an hour away from them, right? It's like right down the street. You can go to them right there. But instead, they had to go to another doctor who literally, what he ended up doing was emailing the specialist, the person who actually knew what was going on, and saying, hey, what do I do? What do I do here, right? And that, obviously there's delays in care with that, right? Because there was always this sort of like, middleman approach. And that would all be gone if we had a single payer system. So, sorry, quick aside.
Thanks, Rich. Sarah, you want to chime into what Ron was saying a second ago?
Yes, which was in response to Nicole's question about where the bill is. I think we should have a really very real conversation about the politics of this bill and any single payer bill. I think I have not yet heard a good argument against single payer. Like, I have not found an individual that's able to say, you know what, insurance companies are really providing an important service. We need to keep them in place. I haven't heard that argument at all. The only argument that is made ever is a political one, right? That the political feasibility, right? Which is just so sad. And so but I want to even demystify that. Like, what is the political feasibility? What are we talking about? So I found these numbers recently. I found that in 2019, about $12 million were spent on gun rights lobbying in the United States. So $12 million went into lobbying to protect gun rights, right? The NRA specifically spent 1.74 million, right? So the NRA put that much money into protecting their ability to carry. So 12 million went into gun rights. 28 million went into HMO lobbying. The health insurance companies spent 28 million. That's more than twice the number of dollars as the gun industry. Why? Why do they need to spend that much money to control the conversation? Kaiser Permanente in 2019 spent $2 million in lobbying. That's more than the NRA, right? So we have to talk about this. They're directly obstructing the conversation, right? No different than when Big Tobacco was lying to us about tobacco being harmful to us, right? And then professional organizations. This is, the organizations that are supposed to represent healthcare providers like physicians. Too many of their board seats are occupied by individuals who have a stake in health insurance companies. So these professional organizations, I'm being so polite, I'm not mentioning them by name at this moment, but these professional organizations that are supposed to represent doctors and protect doctors' best interests are instead protecting the interests of the health insurance companies. So when we talk about political feasibility, we're talking about money in politics. So we need to ask our politicians to not accept health insurance money so that we can have an honest conversation about healthcare in our country. And two, we really need to be concerned about who do these professional organizations really represent? Are they really representing doctors and so on? So that's what we're talking about.
So I just want to say, I see the questions popping up, but I just want to go, this is tying back to what I say every single week. AB 1400 is an exploration bill. It is safe to vote yes on this, Jim Wood. I'm calling him out now. It is safe to vote yes on this, Autumn Burke. It is safe to vote yes on this, the entire damn health committee. Why? Because Governor Newsom and Anthony Rendon and Tony Atkins get to appoint the board, number one. So if you want friends of friends, your friends get to literally appoint the board who make this thing. Not that I agree with that, but if that's what it takes to get the sucker passed, I will be nice. And then I still have to build this out. So when that board gets formed, then they get to pick the committee. And then we get to work. Well, I say we because I'm going to basically, I don't know, I'll bribe whoever with In-N-Out to get on that committee or something. And so then we get to build this out. Then we get to answer those questions that we can't answer right now that are written in the bill board to decide. That's where they start deciding. So until we pass this bill, we cannot build this out. Really, we have to get the bill to pass to really even go forth with the waivers. So to go forth with they have until 2022, 23, I think 23 to apply for the waivers as written in the bill. Now if the bill become a 2-year bill, I'm pretty sure that 23 might turn to 24 or 25. So truthfully, AB 1400 may not go to the hands of Californians for quite a few years now. But if we do not start this process like yesterday, then we will not get it into your hands before the next pandemic hits. And we need this before the next pandemic hits. And that's T-minus, I would say less than 10 years, 10 years or less. And so I just want to emphasize that because it is imperative that our legislators who have not read this bill in its entirety to understand this, understand that you are not voting to get rid of your dinners with the health insurance company. They can still fight me on this later on. Just pass the damn bill and let me go explore how to build it first. Okay, back to questions. Lynn had a question.
So she has two there. And so, but we'll do the first one and then go over to Erica and Sarah, and then come back around, I think, to her second one, which is about funding mechanisms. But so Lynn asks, what happens to concierge doctors? So first of all, we'll kind of describe what is meant by a concierge doctor. So, so first of all, currently, there are plenty of doctors who you can just pay money to see them and they will see you. A concierge is a little bit more than that technically. It's usually somebody who asks you to kind of subscribe to them to pay like a certain amount for a year, and it gives you a certain kind of special access to that doctor. And then sort of leaves you mostly to navigate the issues of like what pays for your drugs or tests or other things that doctor might set up for you. And so why do doctors do that currently? Well, some say, well, they want to be available to some of it is sort of like fancy services for very wealthy people. Some of it is that people are so fed up with dealing with insurance because it's really, really, exasperating, and that they want to just be paid and take care of people. It's a combination of that. So what would happen with all that in CalCare? So actually the bill has a pretty in-depth discussion of this issue. And it says that, so if a doctor, we'll just use a doctor as a general term for this type of provider, says, decides, so a doctor can say, I don't want to have anything to do with CalCare. They can do that. But if they, and I just want to be paid cash for what I do, they can do that. But if they get paid cash to do stuff that's sort of CalCare covered stuff, then they have to send in this kind of affidavit to the state that says they're doing that, they're doing their own thing, and that for 2 years, they can't then be eligible to have CalCare pay them for services that they would provide. So it forces them to make a decision, which is, do I want to do that sort of like narrow thing, or do I want to, deal with the bigger pot, which is where most people live and exist in. And that is intended to create a situation to avoid the situation primarily that you see in the United Kingdom, which is a problem in the United Kingdom. So I think, Lynn, the answer is that there would still be a little narrow rim of something like concierge-like possible, but it would be very narrow because people can't be in and out of the system. So I think that's the answer to that question. And then I know there were some hands up that we can circle back to Erica and then Sarah, which may be hearkening back to comments made a few minutes ago, but go ahead. Bridge.
Hi, yes. Going back to what Sarah was talking about, and I just wanted to add, in addition to professional organizations, Sarah, that you mentioned but didn't name, it's also foundations that are funded by whatever it is, health insurance companies, you name it. That's, that reminds me of when Jeff Bezos, he has his charity, and people started fighting back and saying, why don't you just pay your workers a living wage? And so it's this game that the wealthy organizations play, where it's like, for PR purposes, they have this charity or this foundation that does some good for a small, select few people. But really, if they, were operating, in an ethical manner, there's no need for that foundation or charity. There's somebody I met through Black Lives Matter, and his name is General Jeff. He's also known as the mayor of Skid Row. And he taught me, so obviously he works a lot with the unhoused community, and he taught me what poverty pimps were. And again, poverty pimps are their charity organizations. So I'm not talking about in healthcare, but to work with unhoused people that we all know and love. But he made the point that they're not really solving the problem, because if they were to really solve the problem, the people who work there work themselves out of a job. And so it's like they're doing a little bit and having glossy flyers that show some of the legit good work, but it's not really about solving the problem. So I just, that reminded me of that. And then when you talked about the politicians, hold on, babe. And when you talked about the politicians, I've learned that anytime something that costs money, so CalCare, gets rid of the insurance company, so they're going to lose their campaign contributions. That's where you'll often hear, I'm so for it, but you know what, let's put it on the ballot. Let's put it on the ballot. Any difficult thing that legislators don't want to deal with, they suggest putting it on the ballot. And I find that newer activists are like, oh, okay, but it's really the legislators and the legislators' job to deal with these tough things and pass things like CalCare through legislation. Once it's on the ballot, it takes one commercial from one well-funded insurance company or whatever to sow enough confusion or, just dislike for the bill, and we lose. We can never compete with money like that. And then finally, the last thing I learned when you're talking about politicians, Sarah, is I learned this from Black Lives Matter. Private conversations with a politician doesn't mean anything. It is public actions. So privately, a politician can tell you how much they, I'll just use CalCare, love CalCare, want to support it, but they're in a tough spot. They just don't have the power. And that's a game. That's, and then the person leaves and they're like, they're really nice and their heart's in a good place. No, do your job. This is your job. It's tough. So it's not about private conversations. It's about public actions.
Thanks, Erica. Sorry. No, you do too much with your life and you're like organizing 3 things at once, and I'm responding to a meeting for tomorrow, and then I'm doing this, and I'm just like, why, like Erica said, why am I doing a politician's job? Literally what I'm doing. I'm a full-time nurse manager and I got to do a politician's job too. And they don't pay me. I don't get paid to do this. Just for anyone out there in Facebook land, this is 110,000% volunteer. Everything we're doing through Healthcare for All Los Angeles, Sarah's binder to Dr. Ron Burbaum, to Dr. Bill, to Dr. Rich Wynn, all of that is, we're 100% volunteer organization. So I will just say, if you want to donate to Healthcare for All Los Angeles, you can put 5 on it, because we are 110,000% volunteer. We are dedicating our time here voluntarily. You know, Dr. Ron and I are here every weekend because we are that passionate about fixing this healthcare system, and we're 2 people who are well entrenched in it. So I just wanted to add that. But I know Lynn had a second question that I don't think we got to. I'm trying to go back into the chat and grab it. I think I see one from Lynn about the 46 Democrat Assembly members want to see the financing mechanism before they decide to vote yes for AB 1400. Ash has said that he is working on the financing. Legislators will no longer vote on a policy bill. To say yes, that is very true. Assembly member Ash Kalra has, you know, he basically had put pause on the bill to do this because he knew he did not have that support. As much as we didn't want him to, we were trying to get that education out there that this is a policy bill. Like I said, it is written in the bill that the financing will be built. But it is, unfortunately, the funding thing is going to be the scapegoat of the century. This is going to be like what Nixon tried to use to get out of what is that, Watergate? Yeah, that's what this is, because that's what they used the SB 562, and now they're using it for AB 1400. It's a scapegoat. Do not let them loose on this. Remind them that this is an exploratory thing that cannot happen until that funding is secured. So they can say yes to AB 1400, and still we cannot go live with it until we get from the approval from the board and from the financial regulatory bodies and everybody that we have not only just the budget, but we have the money in the budget to sustain. So it's not that we have it just to be able to roll out. We have to be able to sustain it, because nobody wants to get this going in 1 year. We're bankrupt. That's not going to happen. But that's what these legislators are trying to get you to feel. They want to make you feel that as soon as this starts, because it costs so much money, not telling you that the current healthcare system's damn near costing the same amount. They're not telling you that, but they're trying to make you feel that this is going to cause California to go belly up, and it is not. But that's what they're going to continue to hide under as long as we let them hide. That's why we do these CalCare office hours, because we want the public and everyone to be well equipped for that bullshit excuse that they keep coming after. Because when SB 562 came out, I believed them. I did. I was naive. I didn't know. I mean, there's still a lot I don't know, but at this time, I know right now I can call them on their BS. So I just want to emphasize that. Call them on that BS. Remind them that this bill will not be implemented unless we get that funding built out and those waivers and everything. So don't let them hide from that. Do not give them that cave. Okay, and then Sarah, I see your hand up.
Yeah, just wanted to add on a couple things that you said. One thing you said really struck a nerve with me about our legislators not finding the time to read the bill. I have friends, I have at least one friend who lost both parents to COVID-19. And the fact that our legislator didn't have the time or didn't feel it was important enough to even bother reading a 66-page bill is really angering. We elect you all to protect us, to take care of us. You could have at least read the bill. And as Jeanna pointed out, none of us are getting paid to read the bill. And if I can read the bill, if Ron, Jeanna, Dr. Bill, Nicole, Erica, if we are capable of reading the bill, certainly our legislators, whose job it is to read legislation, could have at least read the bill. So I just have to say that I find it literally a slap in the face. I don't care about you. I don't care if your family members died. I'm not going to bother reading it. Second, to Jeanna's point, Jeanna brought this up several times before I actually got what she was saying, because Jeanna started ranting about this, I think in February. She was like, let me explore, this is an explore. Yeah, and I didn't get it until I read those two parts in the bill where it spells out that this passing AB 1400 is just the first step. And it says in the bill, and I'm reading from the bill right now, it is the intent of the legislature to enact legislation that would develop a revenue plan taking into consideration anticipated federal revenue available for CalCare. So we would pass the bill, we would then apply for the waivers, we would then assess the federal monies coming in, we would look at the gap left, we would then, the legislature, it's their job. It's not my job to come up with the funding mechanism. Actually, it's their job to come up with it. So stop asking me how we're going to pay for it. So it's their job. The bill spelled it out. Legislators, it's your job to come up with the funding mechanism. Only when that happens, then the second part, I'm reading again from the bill. It shall not become operative, CalCare, nothing in this AB 1400 shall become operative until the date the Secretary of California Health and Human Services notifies the Secretary of the Senate and the Chief Clerk of the Assembly in writing that the Secretary has determined that the CalCare Trust Fund has the revenues to fund the costs of implementing this title. So there is no risk of the state of California going bankrupt, of us turning belly side up if our legislators vote yes on this bill. The yes on this bill is what Jeanna was saying since February. I just didn't get what she was saying, that this just allows us, it helps us articulate that single payer is the most ethical healthcare system. And it sets our intention. It's like entering an address in your navigation. You will not know exactly what streets you're going to go on until you hit the road. Your car starts telling, oh, there's traffic this way or whatever, but you have to put your destination in. You need to set the destination. And that's what we're asking the legislators to do.
I mean, I just got to say, in the words of my mentor and love, Senator and soon to be Congresswoman Nina Turner, hello, somebody. So, I just have to add that because thank you. Yes, that is what I've been driving at this whole time. And that is what I really, as you guys go out and talk to your legislators, please do tell them that exactly what Dr. Sardine just said, because they are going to hide in these caves of there's no budget, there's no funding, I need to see funding. And I'm going to be like, I need to see you on Skid Row because you're getting voted out if you don't get your act together. So I really am like Sarah said, I am tired of putting these extra hours for this. Healthcare for All Los Angeles is a single payer focused organization. So if we pass this, we might just disband. I might just go on a vacation. I don't know. I'm just putting that out there. That is the whole point of this organization. So we are working to basically disband ourselves. If we pass this. Now, PNHP will still exist. I will say that. Sorry, docs, you guys don't get to go on vacation. Keep working. But healthcare for all, we will probably go on some type of vacation. Catalina, something like that, wine country. We will go celebrate and then sit there and be like, and you'll go to our website and see past AB 1400. Bye. Anyway, no, we wouldn't. We are going to see this all the way through. Passing AB 1400, like Dr. Sardine just said, is the first step. So we will be lockstep with the governor, with Ash Kalra, with everybody working on this until it is implemented and probably still beyond. So we will not go anywhere, but I'm just saying that is the focus of the organization. Rich, I see you had your hand up.
Yeah, this was just a follow-up on Dr. Sarah's comment about if they haven't read the bill, be pissed. So the bill came out, I think it was February, right? Something like that. I think it was late February. And Dr. Sarah, myself, and a few others grouped together and had like the most nerdiest book club in the world where we reviewed the bill like day by day. And that was in the height of the pandemic here. I was spending 80 hours in the hospital each week. I was seeing patients, you know, and then at the end of the day, I would come home and I'd read part of that bill to get ready for our book club. If I can do it, I'm pretty sure our legislators should be able to do it. So yeah, be pissed.
Thank you very much for that. And like I said, thank you for, you know, you guys, everyone has been in the hospitals. Like I said, that statement right there, guys, that is, should make an assembly person who hasn't read this bill feel embarrassed that a physician working frontline in the hospital with a new baby has, you know, a beautiful new baby at that, has read this bill on his own time and is still putting effort into getting this passed. And I'm like, so why haven't you? Your whole job is to do this. If this was just my job, do you guys know how much hell I'd be in the assembly right now if that was just my job? But you know, I'm not, and I probably shouldn't be, so it's great. Anyway, I cuss too much, I think, to be on that level. Anyway, sorry, you had another question, or you had your hand up?
While we're on this ranting thing, the number of Democrats that will say, I am all for universal health care, but is single payer really the way to go? And then California, you know, the Democratic Party passes, you know, our platform says we have to pass single payer. Then they're like, wait, but is AB 1400 really the way to get us there? I mean, these folks are slippery, super slippery, you know? And why are they so slippery? I'm gonna say it again, the $28 million that are spent on lobbying by the health insurance companies in just 1 year. And Kaiser spending $2 million. That's 2 million reasons why we can't have an honest conversation about how to make single payer. I hate that we have to waste our time talking about whether or not single payer is the way to go. Sorry, I need to stop now. I'm gonna shut up.
So one little thing I wanted to mention related to Lynn's comment or question, that had some commentary, is that, you know, if you really listen to Jeanna and Sarah, then you get that, like, the bill is, if we think of this as we're trying to build a house, the bill is the architectural plan for the house. And then you have to gather the money and build the actual house. And those are the next steps. And so you don't have to gather the money to make a plan. In fact, it's easier to figure out exactly how much money you need to gather if you have the plan in place, right? That said, it is the case that some people in the legislature have said, well, without seeing where the money's coming from, I don't buy the plan. And it is also the case that the people who have introduced it into the legislature have expressed that they now intend to call the bluff of those people by providing a financing plan. So while it may not be necessary, technically, it looks like they intend to do that. And so, you know, anyhow, these are all some of the features of the current politics of this bill. And you know, and well, I guess one other thing too is that when I do think that PNHP or PNHP won't disappear when this bill passed, because we actually think that there should be a national health program too, and that we actually think maybe one way that would happen is that one state does it, since it, as we've mentioned, it happened in one province in Canada first. But the other thing too is that we are also changing the locus of accountability for healthcare to our government. Right. And right now, it's really hard to hold anybody accountable for what's going on with healthcare, because just try to call the insurance company, see how long it takes to talk to anybody who has denied your care or whatever. So I think that no matter what passes, there's always going to have to be an effort of holding people accountable for what happens with healthcare, and there will adjustments and battles over what's funded and things like that. So I don't think the organizations will disappear, but there may be time for a little vacation, at least once it passes.
Just a little. I mean, just a little.
Well, ours will disappear, but we'll come join you at PNHP. So the organization will be done, but you'll keep us.
I see my role as keeping the wolves at bay, so they don't eat into our public financing and chip away at our public healthcare system. So I'm sure if I live that long, that is going to be my role. I will be then, I'll be another guard dog. I'll take another guard dog position from all the insurance companies or whoever it is, corporate, that once we get it, when we get it, that we make sure we keep it.
Exactly. So I see, thank you, Paul, for dropping these, but another comment from Lynn. She said, my assembly member, Mark Berman, told me in a Zoom meeting with the top Democratic leaders in Santa Clara County on a call that he doesn't feel that he can promise his constituents a plan that is feasible until he's sure it is, excuse me. We all know that showing that the system is worth paying for in a policy bill. He said that he has been meeting with Ash Kalra to discuss this. I mean, personally, I understand, and like, you know, I could say, okay, yes, consider your constituents, but I was like, I kind of, my facetiousness and my a-holeness wants to come out, and I'm like, yeah, but do you consider, for, you know, your constituents when you like vote on fracking bills, or, you know, when you kind of like just vote to increase gas taxes again? Do you consider your constituents then, or is it just this, or no, yes, no? I'm sorry, that's just me being a little bit facetious on that. Anybody else want to chime in? Sorry.
Well, I think that was the thing that I was saying, that the bill authors are calling people's bluff on this stuff by working on financing plan, and that eventually, like, nobody has to feel like we have to run away from that, of just of being straight up with the public about where the delta in some ways described, where the money that's between the existing public expenditures will come from. So I see Dr. Bill's hand raised.
Yeah. And I know Sarah wanted to chime in on something once we got the questions answered.
Well, I would kind of like to address Lynn's question. And we had a person who kind of creates controversy, but I know her a long time, Melahat Rafai, who's secretary now of the California Democratic Party. She was our guest speaker today in the PDA healthcare town hall. And, you know, she said you have to put it to these people. I think it was Mary Carter brought it up about her assembly member, Cotty Petrie Norris, down here in Orange County. Said kind of the same thing, you know, like, yeah, but, you know, I'm not sure that this is going to really work out, you know, or something like that. So, so she suggested putting it to them. Well, what's your idea? Because if you have an idea for it that's better, say, than the Canadian system, or, you know, or any number of models that are out there already, you know, public scientists and economists back this system. So if your idea is better than the science that's available, please share that with us. You know, let's go with your idea if it's better. But, you know, I mean, the president now even is saying he's following the science on COVID and, you know, the epidemiology and vaccinology. Well, you could follow the public health science too, and figure out that we would be saving money and saving lives by going to AB 1400. You know, that's, I think, the underlying message to these, you know, these people who are taking, I absolutely agree with Dr. Sarah, they are taking big bucks, but the only way to marginalize the effect of the money is to get the people on our side. And the way we get the people on our side are arguments like that, to say, well, you realize by saying that you're ignoring science and good models that are out there. So if you are ignoring that, what's your, you know, better idea for this?
I don't remember if it's me or Betty.
No, you could go.
It should be, yeah, it's you then, Betty.
No. She could go. Sarah can go. I'm not, you know.
Oh, okay.
I love Dr. Bill's point there. Like, okay, so you don't think this is a good idea, but I'm sure you really care that so many people are dying and suffering. What is your great idea? It's a really good point. A few weeks ago, I joined CARE, the Council on American Islamic Relations California branch, to lobby my state assemblyman on 3 bills. And 2 out of the 3 bills had price tags attached to them. Does anyone want to guess what question I was not asked during that meeting? Not a single person asked, how are we going to pay for it? Yes, Erica, is that what you were going to say? I just remember walking out of the meeting and feeling so insulted. How come nobody asked that question? Just to point out that bills are considered and passed every day, every year, that don't have the funding mechanism attached. Although I get it, bigger price tag. But still, we are in a dire emergency. And I wanted to draw our attention to another really emergency that our state is headed into if we don't pass single payer. Recently, our local school district is trying to come up with how to pay out OPEBs to their teachers and staff. So those are OPEBs are other than pensions, post-employment benefits. So I'm going to read a quote from this report called The Challenges of Health and Welfare Benefit Costs for California. This is for school districts. So it says most school districts continue to provide health benefits to their employees after they retire. As more workers retire, the costs of these retiree benefits consume a larger share of district budgets. Moreover, districts have often not set aside funds to pay for these benefits while employees earn them. In some districts, this has resulted in unfunded liabilities totaling many thousands of dollars per student. So if we don't pass single payer healthcare soon, a lot of our school districts are going to end up upside down, because when they hired teachers and staff, they promised or made commitments to offer them benefits after retirement, but they didn't actually set aside the funds. How are we going to pay for that? I'm just going to ask that. How are we going to pay for that?
So actually, let me, so Betty, we will come back to you in a second.
No, let Nicole go first. Anybody, just,
right,
I'm fine. I can wait.
Yeah, Nicole's question, actually, so I think Sarah started to answer some of it. So let's, Nicole's question, I have to cycle back in the chat for a second, get my little bar back, was a good one, which is said there are a lot of people running for local offices within the state and for federal offices. And what are some way that those campaigns can help support these efforts? And actually, Sarah, I think, began to answer that question in part, especially with respect to local offices. And so, because one of the facts that we face is that healthcare costs are a big cost for local government. And recently, I had a discussion with a guy named Kenneth Mejia, who is running to be the controller for the city of Los Angeles, and about some of these issues. And we may have him come on to talk about these things, but it's like the issues with schools who have big unfunded healthcare pension liabilities. And one of the reasons they do is that some of the folks who work in the public sector will retire before they hit 65, or there will be supplements to Medicare that are part of what was promised to those workers and negotiated in their labor agreements, but the money isn't all there to pay for that. Those would end up potentially like really taking away from other services that municipalities and other things provide. So there's a lot that's very important related to local government. And it's a big part of their spending is on healthcare for the people they employ. And this would help them, but drawing those connections is important. On the federal side, this is there's sort of an interesting discussion. And I think also our next week's, one of our we have a guest coming next week who is a single payer sort of policy thinker and strategist named Michael Leidy, who has thought a lot about kind of these issues of how a state program would interact with federal programs. It's related in part even to some of the questions Eli was asking at the very beginning. So there's certain parts of federal law already that say that primarily the Affordable Care Act, that say that states can apply to get waivers and things like that, and then that you can use the money in this sort of different way. There's some people who have felt that it would be easier if the federal government changed some laws to make this easier. We don't think that absolutely is necessary, but it still might be the case that it might be easier. So there's actually federal legislation, the state introduced by a California congressman, the State-Based Universal Healthcare Act. That's something that's RoCana from Northern California introduced. It's something that people in federal office could also support. And then the other thing, of course, is that people in politics know each other and interact with each other. And it does matter if the members of Congress say, you know what, maybe right now it's hard to pass single payer at the federal level with a Senate that's 50-50. We're like having trouble passing, but in California, we have these super duper majorities of Democrats and a party that's endorsed this particular approach. So one thing is building the political case through the whole spectrum. One good activity that HCA-LA has really been involved in and others has been organizing, going to neighborhood councils and city councils and getting them to pass resolutions. So Nicole, I think your question, both from a political standpoint, but also from a policy standpoint, is a really important one. And we want to engage people, not just who are in state government on this.
Absolutely.
So let's see, where are there other questions? There's hands up. Let's see. While I was bloviating.
Yeah, we have Betty who's been waiting, and then we can go back to Sarah, and then let's see if there's anything in the chat.
Yeah, speaking on that part, Dr. Bill's wonderful about telling you how it would save all city governments money. And I love it when he always comes at, but it's going to save all city governments money. I'm like, you see? But I just want to say that yes, let's talk about it. Let's try to get it up. Let's try to do our best to get the funding out there and the knowledge about how we're going to save money and save programs and be able to fund this and fund that. But ultimately, we all know in this room that AB 1400 can be passed as policy, and the funding can come a little later in a subsequent bill. But also, I want you to keep in mind that, that as a person who's impacted by this healthcare system, and also, our economic system, it's a false narrative to put it out there that we don't have the money for this in any capacity. We do. And I'm at this point, and I'm just so naive or something, I don't know. I'm thinking we might be able to do it in California even without the federal. But I don't want to leave those on the table, those federal funds. But I'm having a feeling we might be able to do this because, we've gone with how much billions of dollars in fraud, not getting back, $76 billion in surplus, giving away $1.5 million. So, I think that's a long shot, but the fact is that what I'm trying to say is that the money exists here in this country. We are the richest country in the world. And in California, we are the 5th largest economy. The money exists.
Thank you. Yeah, we know we have the money. It's just that it's kind of like, one of those situations. I know we're coming to the close to the end of time. It's one of those situations where you need to pay for something that you may not want to kind of like, it's one of those adulting things. Like, I got to be an adult and I don't want to pay for this. I want to go do something more fun with my money. Even though I don't think supporting, like, you know, fracking or anything like that's fun. But I feel like that's how the mindset of the legislature is that they don't want to fund this because it's not fun for them. And it's hard work. And that's even in the CHBRP bill, or excuse me, the CHBRP analysis, that it is going to take a lot of work to make this work. And that's true. It is going to take work. It's going to take some late nights and early mornings, a lot of pizza and a lot of caffeine to make this work and to build this out. And I think our legislature has honestly gotten lazy. They want it quick, in and out. As soon as I do this, it's done. You know, as soon as I say yes, it's done. It doesn't require any work. I don't want to do work. But let me tell you, you get paid six figures to work. So work. My money paying you to work. That's the problem. And I think that overall, the overarching thing here is that they really just, it's too hard to them. You know, that's the problem. That's why they scapegoat it with, oh, there's not enough money. There's not enough anything to do this, because the overarching theme here is that this will be one of the hardest things to do, probably since the passing of Medicare. And somebody's got to do it. I mean, should I start training Rich's baby to do it right now? I mean, she's an infant, but she's going to be smart. So I guess I should start training her, because at this rate, I'm getting ready to kick it to her generation. And for those of you who guys aren't in Zoom, Rich's baby is literally a newborn. So I'm just putting that out there that if we don't do this now, I'm passing it to her generation. And that was passed to my generation. And I really don't want to pass it to her generation. I'm already worried about our climate. So, you know, if I could at least take healthcare off the table for her, she can fight the climate part. I don't know if I can do both, but I can at least get healthcare. So that's what I'm saying. It's really complex. Passing AB 1400 is not the hardest part. Building the system is going to be the hardest part. And it just seems that our legislation and the assembly people and the senators and everyone kind of coming up with every single excuse, it just seems that they don't want to put in the work to do it. And that's what frustrates me. And just like Sarah was saying in the beginning, it's frustrating that, you know, some of them haven't even read the bill. That's frustrating. But anyway, we're going to get ready to wrap this up. So Sarah, I see you have your hand up. And Paul, can you check the chat for any last questions, please? I appreciate it.
I just wanted to close the loop on the schools thing and then say one thing kind of from my perspective in closing. You know, when people talk about how are we going to pay for this, they forget our schools are one of the largest employers in the state, right? And the cost of providing healthcare is the most burdensome right now. Of all the things that they have to pay for our staff, our teachers, healthcare is the most burdensome on our school districts. And so we said this in the chat and I just wanted to say it loud here. So what districts are doing is they are over time shifting over responsibility for paying healthcare more and more onto our teachers. And teachers are already not getting paid enough. So the question about how are we going to pay for it, we're already paying it in very screwy ways. What we're talking about is unburdening systems that benefit the masses of people, like our public school system, and then through a progressive tax scheme, those who have some to spare might be carrying a little bit more of the cost. But I wanted to share one observation I've made of human beings. I know maybe others of you have done this too, fundraising. I'm sure everyone has some experience here in fundraising. I have found the following thing. I am not joking. I have had times when I'm fundraising for something that's like a human cause, like housing or food collection or toy collection for kids. And I will find the wealthiest people I know will say things like, well, I don't know, I'm going to get taxed really high this year. I don't know if I'm going to be able to afford this year, maybe next year. I'm worried I might not be able to cover my expenses, right? So I'm used to getting that response often from some of the most wealthiest people I know. And then I know people, this has happened very often, where someone I know doesn't have money to pay rent that month. I have had this happen several times. I know they don't have money for rent, and they will hand over a big chunk of what little bit they have because they want to take care of another person. So the human nature of it, that the more we have, the more anxious we get, the more we are unable to see we spend more time in fear and anxiety of what might happen so that we can ignore what is actually happening right now. I'm going to say it again. Our fear of what may happen should not outweigh the grotesqueness of what's happening right now. I'm just going to leave it.
And with that, we're done. Because it's 7 o'clock, and I think that was an excellent closing statement. And going back to AB 1400 and to the legislators and to people who are worried about what is going on or what would happen if, and they're playing the what if game. What's happening now are people are dying. We have millions of uninsured right here in the glorious, dry, running out of water state of California. So, you know, some key take homes here is legislators, read the damn bill. I saw that, Sarah. And then you guys, you know, we do need to take care of each other, and we do need to, you know, look after each other. And it's unfortunate that some of our most wealthy can't see that as well as some of our most poor. But with that, I wish you guys a wonderful night. I want to say thank you on behalf of myself, Dr. Ron Birbaum, HCALA, PNHP, and everybody else who is out here in the struggle with us. You guys are my brothers and my sisters. I love you all. Please join us again next week. We will have Michael Leidy, who's president of Healthcare for All, or excuse me, Healthy California Now. I'm sorry. It's getting close. It's the end, obviously. Who's going to go in a little bit more, and hopefully we can really peel apart and get a little deep on this bill and the healthcare for now, our Healthy California stuff. And I keep saying that because it's the same initials. I'm sorry, but we will be once again back here tomorrow. Yes, next Sunday from 5 to 7 p.m. I'm butchering this ending. You guys have a great evening. You take care, everybody.
Take care now, Jeanna.
Jeanna.
Bye. Take care.
Thank you, Nicole. Great questions.